Welcome to Ulnar Nerve Made Ultra Easy tutorial. In this video, we will be looking at the clinical and surgical aspects of the ulnar nerve. The ulnar nerve could be affected in many parts as of its cause. It could be affected at the medial intermuscular septum, the arcade of Strathus, the medial epicondyle, the cubital tunnel, between the flexor carpi ulnaris heads as well as the Guyon canal. The most common lesions will be the ones at the cubital tunnel as well as the Guyon canal. Some causes of the high lesion include cubital tunnel syndrome, elbow fractures, ulnar subluxation, cubitus valgus deformity, the inflammation of the ulnar nerve, as well as flexion carpi ulnaris heads compression. Low-risk lesions include laceration, trauma, lipoma, ganglions, Guyon canal syndrome, as well as repeated movements at the wrist. In a high lesion, all the muscles supplied by the ulnar nerve will be affected. The palmar and dorsal sensation of the medial 1.5 digits will also be affected. In a low lesions, all the muscles supplied by the ulnar nerve except the flexor carpi ulnaris and flexor digitorum profundus medial 2 heads will be affected. The sensation will only be affected at the palmar medial 1.5 digits. The dorsal will be spared because the dorsal cutaneous nerve has exited before the nerve enters the wrist. A nerve lesion may produce many symptoms. It could be pain, numbness, tingling sensation, pin needle prick sensation, weakness of hand grips and dexterity, loss of fine movements, and these may all affect the daily activities. Some signs that could be elicited will be on inspection. A deformity may be noticed. You can notice a less prominent claw hand in a high lesion and a more prominent claw hand on a low lesion. A more prominent claw hand is seen in a low lesion. This is because of the sparing of the flexor digitorum profundus, counteracting the loss of the medial lumbricals. Hence, it causes a more flexed distal interphalangeal joints. On inspection, there will also be guttering of the interossei muscles, wasting of the first web space, as well as hypothenar flattening and wasting. Frontman sign test for adductor pollicis. The first picture shows a normal adductor pollicis. The second picture shows a weak adductor pollicis. The person will not be able to hold the paper between the thumb and the index finger as shown in the picture 1. Tinel sign is positive when tapping at the nerve along its course produces pain or tingling sensation. Weakness of the hypothenar muscles will also be seen. Abduction of the little finger, flexion as well as opposition of the little finger may be difficult. Abduction by dorsal interossei and adduction by palmar interossei will be also difficult in a lesion of ulnar nerve. Some investigations include X-ray to detect any fractures, dislocations, electromyography, nerve conduction studies to test the speed of the nerve conduction, ultrasound, CT scan and MRI to detect any cyst, soft tissue swellings and rule out other disorders. Blood tests could also be done to detect any infection or inflammatory markers. Moving on to the treatment of the ulnar nerve lesions. Usually, we start off with the conservative management. Adequate rest is always important. Immobilization will prevent movement of the joints or the limbs excessively. Using a night splint will also help. Avoid gripping movements, repeated movements at the joints. Physiotherapy helps to strengthen the muscles and allow daily activities to carry on fast. Medical management includes pain management. You could give NSAIDs or other pain medications according to the WHO letter. Neurobion is sort of a vitamin for the nerves. Surgical management includes cubital roof release, where the fascia above the cubital tunnel is released. anterior transposition of nerve, medial epicondylectomy, and nerve exploration with ligamental separation at the Guyon's canal. Ulnar nerve transposition is a surgery involving creating a new tunnel in front of the medial epicondyle and moving the ulnar nerve into the new tunnel. Medial epicondylectomy is a surgery with removal of the medial epicondyle, a bony bump on the inside of the elbow, allowing the ulnar nerve to glide smoothly when the elbow is flexed and straightened. In cases of a low lesion, at the wrist area, a small incision is made. A ligament attaches between the pisiform bone and the hook of hamate. That ligament is separated, and then the skin above is sutured back together. The loose ends of the ligament remains inside. This is known as the Guyon canal nerve exploration and ligamental release surgery. Most surgeries comes with complications, and some of these complications includes pain, infection, numbness, scarring, as well as some stiffness. We have come to the end of this video. Thank you.